He was right. I'm a trauma surgeon for more than 25 plus years in Sancheti. I do exclusive trauma. But then nowadays, we are seeing more and more periprosthetic fractures, especially in the geriatric age group. So if you look at the incidence, it's about 2 to 3% after 15 years, more so with revisions. And as far as outcomes are concerned, you have a high rate of loosening, refractures, and failures to the extent of 10 to 20% as published by Javed Parvizi. We all traditionally follow the Vancouver classification, where you have the type A trochanteric fractures, type B femoral shaft fractures around the stem, and type C, which is the intercalary fractures. If you analyze this and see the systematic review, 2017, the type B fractures are the most, which are 86%, and out of them, B1 and B2 are the commonest. Now, what is the most crucial point as far as these fractures are concerned is to correctly assess whether they are B1 or B2. Because it has been well documented that there are about 20% errors of judgment when you say it's B1, and instead on the table you find that it is B2, and then you have to change the plan intraoperatively. Nevertheless, you need to keep both fixation as well as a revision replacement ready when you're doing these fractures. And the most important way to diagnose whether it is B1 or B2, that is whether the stem is loose or intact, is the intraop stability test. In fact, Lindholm published this, again, a systematic review with 321 periprosthetic fractures, and he concluded that we are, as surgeons, bad in making a decision whether the stem is loose or not. He, along with Karl Stoffel, published this algorithm based on clinical history, radiographic analysis, as well as intraoperative findings. And if you go by the algorithm, almost 80 to 90% of the times, you are quite okay in terms of diagnosing whether the stem is loose or not. This is a free to download paper by Karl Stoffel, and you can very easily access it on the internet. I'm not going into the details of that algorithm, but it is based on all the three parameters: clinical history, radiography, as well as intraoperative findings. Michael Stutz presented a unified classification much on the lines of the AO trauma classification, where he numbered the joints 1 to 6, bones were as per the AO, and types were as per Vancouver. So you have, as far as hip is concerned, the 4-3A, which is trochanteric, 4-3B1, where the stem is intact, B2, where the stem is loose but the bone is good, and 4-3B3, where both are bad. Then C is intercalary, D is close to a total hip, and E is close to a total knee. So this is the unified system of classifying periprosthetic fractures. Let's see management. There's no role of non-operative management. However, you need to minimize the surgical trauma. These patients are severely comorbid and geriatric usually, and keeping them bedridden is a strict no. This is a short mnemonic which can tell you how to manage these fractures, and it is a SPAM. So you stabilize the fracture using long plates, preserve the hip function, achieve bony union, and maintain component stability. In general, if the stem is loose, you need to change it and use a new implant as an intramedullary nail, and mandatorily augment with extramedullary fixation. If the stem is stable, then you keep the stem, use extramedullary fixation using principles of relative stability. When you fix, you very often need to employ principles of relative stability and minimally invasive plate osteosynthesis. Mind you, longest available implant should be on the table, spanning the whole bone. You rarely can do absolute stability using interfragmentary screws, but what should be there on your table are special tools like special periprosthetic plates, short unicortical periprosthetic screws, excellent locking attachment plates are available, cerclage wires, better cables, and better are cable mounts where you can put the cables through the plates. And at times, if the bone quality is extremely poor, you may need a fibular allograft or an autograft. So all this should be there on your table. Very rarely you can do a absolute stability. Don't make it as a rigid plate construct with short plates, because they invariably fail due to very high stress concentration. This was the first specialized periprosthetic plate by Zimmer, which became available long time ago. It had multiple options for the greater trochanter, multiple options for screw placement, cables going through the plate. It was sided. Suddenly Zimmer went out of the trauma scene, and now it's no longer available. But this is a special plate launched by Synthes. Just last year I saw it in Davos being demonstrated by Karl Stoffel himself, and it is probably the game changer, because it has multiple trochanteric options, the hook as well as the ring. It has a lot of modularity as far as shaft fixation is concerned. It has the provision of cables through the plate, locking attachment plates, distal extension as long as you want, because you need to span it right down to the condyle, with availability of variable angle screws around the stem. So this unfortunately is not yet launched in India, but what is available to us are these are standard periprosthetic plates with these locking attachment plates. These are extremely useful proximally where you cannot put screws because of the stem, and instead of the cables, if you attach this plate onto your periprosthetic plate, then you can circumvent the stem as shown in this figure and pass locking 3.5 screws. Then you need cable mounts, unicortical periprosthetic screws, and cable tightening assemblies. So this is how it fits. An example of one of my cases, this was an Austin Moore. The stem was good, so fixed it with a long banana plate, which is the periprosthetic plate available by Synthes, along with a locking attachment plate here. And you can see that I could place 4 screws proximally with only one simple wire. And this, it healed at 3 months, and this is at 9 months. The patient is walking full weight bearing. You may need to at times contour the plates when you don't have those specialized periprosthetic modular plates, and you must keep a strong bending press ready on the table. Type A, which are trochanteric fractures, don't treat with just cerclage wires or cables or tension band wiring because they have a high failure rate. What is recommended is hook plates or the ring plates attaching the trochanter to the shaft, because otherwise they tend to break and fly off. If the stem is, this is an example, B1 stable stem. When do you use allografts? Now, in such a comorbid patient with severe osteoporosis, what you need to do is keep the ability of that patient to transfer at least from bed to the wheelchair to the toilet, and therefore you can augment the poor bone with fibular struts either anteriorly or medially. And it is indicated when you have a poor bone stock or severe medial comminution, or where the bone is not really up to the mark, because it has been shown that they improve stability with excellent results. What you need to do is burr the shaft, attach the fibular strut there, and then attach it through the plate or extramedullary. So reconstitute the tube, and this can be done over the reimplanted prosthesis also. 3D intercalary, you can use standard fixation principles. Be sure to use the longest available plate spanning the whole bone. Cerclage wires are as good as screw fixation. Nowadays can be done minimally invasive percutaneously. Cables are better than plain wires, and if you have a cable mount, then it's even better. A few cases, this is a 71-year-old type B1. Now this was a lady who could not afford any of the fancy plates, so I had to use a reverse distal femur LCP of the opposite side, cerclage wires proximally, and 1 year later it healed, though there's some subsidence of the prosthesis, but it has healed. She's walking with a cane. Another 75, this was a THR done 10 years ago. The patient was a community ambulator, and the stem was stable as per Stoffel's algorithm. So this was fixed. Now today I would not use such a short plate. I would span the whole bone. Fortunately, this healed. This is about 14 months post-op. Another example, now see this. This was a lady who had come to me about 6 years before the hips were replaced with bilateral distal femoral fractures, and I had fixed with a plate. And the plate was a standard length of the plate because there was a prosthesis hub. But probably if I had spanned the whole bone, then this wouldn't have happened. So I had to revise it and take that plate all the way up, and it healed at 6 months, 9 months, walking with a stick. And this is at 1 year. Another example, a 76-year-old male, B1 fracture. This was the stem. While we were debating whether it is B1 or B2, we fixed it. Similarly, now here I have used a locking attachment plate along with cables, along with unicortical periprosthetic screws, so everything that was available, and it healed predictably in 1 year. This is a 1 year X-ray. Last two cases. Today, we do not have that VA-LCP from Synthes as yet, but we have excellent Indian GTR plates, which are not very expensive, cost about 35,000. Now, this is a case where the patient had a total hip and a total knee down below, and this was the fracture. The stem was stable, and this is an Indian GTR plate. Now, it has a hook. I have used two 3.5 millimeter screws. I have used it as an absolute stability, but then I have spanned the whole bone, and this healed nicely. Last case, 86-year-old male, fall at home, stem was stable. Again, the same plate was used. Circlage, absolute stability using 3.5 screws, and it healed. So where do you not fix it, even if you feel the stem is stable, or where you have a lost medial cortex, then the stem may become unstable later on. Or you have a very short oblique or a transverse fracture just distal to the stem, or severe combination or a bone gap. Those are the patients where you need to revise the prosthesis to a long stem prosthesis, which the next speaker is going to speak on. And these are the fractures which are not amenable for only fixation. So to conclude, use a patient-specific approach, balance your surgery against early mobility. The entire crux is to decide on table whether it is B1 or B2. If the prosthesis is stable, plate the fracture, bridging the entire bone, keep entire armamentarium of the periprosthetic fixation ready with you along with a revision. So you should have an arthroplasty surgeon with you if you are not doing one. Like I don't do an arthroplasty, so I have to keep somebody as a backup. Consider medial or anterior fibular allografts if the bone is poor or if there is a gap. If the prosthesis is loose, change it. Use the new long stem prosthesis as an intramedullary nail and fix the tube around it, but mandatorily augment it with extramedullary fixation. In all cases, you change the scratched head or worn poly if you see on the table. Thank you.